Good evening. We would like to extend a very warm welcome and thank you all for being with us here today at the launch of National Institute for Health and Care Research, Global Health Research Center for Multiple Long-Term Conditions. We are excited to receive this grant to undertake research to better inform treatment and care of people living with multiple long-term conditions in low and middle-income countries. The program will begin with the inauguration of the center, followed by a panel discussion. May I request Professor Sanjay Zodpe, President, Public Health Foundation of India, and Professor Prabhakaran, Distinguished Professor of Public Health Foundation of India, to escort our guests and felicitate them with a token of appreciation. Professor Vinod Paul, Member Niti Aayog, Government of India. Dr. Rajiv Pahel, Secretary to Government of India, Department of Health Research and Director General, Indian Council of Medical Research. Professor Kamlesh Khunti, Professor of Primary Care, Diabetes and Vascular Medicine, University of Leicester, and Director of the NIHR GHRC for multiple long-term conditions. Dr. Sylvia Ainen, Senior Global Health Research Manager, National Institute for Health and Care Research. I would now like to request Professor Zodpe, President, Public Health Foundation of India, to deliver the welcome address.
Thank you and good afternoon to all of you. Distinguished dignitaries, Professor Paul, Dr. Raju Bail, Professor Kamlesh Kunti, Dr. Sylvia Annie, my colleague Professor Prabhakaran, Professor Reddy, invited guests, PHFI colleagues, and ladies and gentlemen. It is an extraordinary privilege to welcome you all for the launch of Global Health Research Center for multiple long-term conditions at Public Health Foundation of India. At PHFI, since its inception, we have contributed significantly in advancing the cause of chronic diseases. Professor Reddy and Professor Prabhakaran, Dr. Monica Arora and team at PHFI played a very important role in the context of multiple long-term conditions over the years. And we see this initiative as a continuation of that work that we have been doing over the years. And the characteristic of this grant is that it has multiple dimensions which are critical in advancing and responding to the challenges related to multiple long-term conditions. On one side, it has a strong research component. On another side, it has a strong capacity building component too. It has strong community-based or community-related work context as a part of the grant. It has a technology component and also a health systems connect. And then I believe that all these are so connected in advancing the challenges and responses that are critical for the multiple long-term conditions. In that context, this grant is unique. This is a collaborative effort. The University of Leicester, PHFI, we have institutions from India also, Nepal. And I firmly believe that we would be able to, through this grant, next 5 years or so, not only answering challenges in the context of grant, but also contributing to the national program and influencing the policy. And in that context, therefore, for this launch, it is our pleasure to have you all, and we look forward to your support in taking this initiative forward. Thank you so much.
Thank you, sir. May I now request our distinguished guests, eminent speakers, and co-applicants to kindly come forward for lighting of the lamp on this auspicious occasion. Thank you, everyone. I would request Professor Prabhakaran, Distinguished Professor of Public Health at Public Health Foundation of India and the Director of NIHR's Global Health Research Center for Multiple Long-Term Conditions, to share an overview of the grant.
Good evening once again to everyone. Professor Paul, Dr. Bahal, Professor Kamlesh Kunti, Dr. Sylvia Annie, Professor Zodpe, Professor Reddy, dignitaries in the audience, other luminaries, friends, and ladies and gentlemen. A warm welcome to all of you. It's indeed a great pleasure to welcome you all to the launch of this center. We in India believe in two things. One, we believe in yoga, which is supposed to provide holistic care to keep yourself healthy. Second, we believe in Vasudhaiva Kutumbakam, which means the whole world is a family. And today is an example of how the world's family has come together. We have guests from UK, US, Finland, Italy, Israel, and maybe I left out some. So the research that we do today, or the center that's going to work on the various aspects of multiple long-term conditions, will inform science as well as policies across multiple countries. And that's a mandate that has been given to us. So here I am to briefly explain as to what we are planning to do in terms of the Global Research Center for Multiple Long-Term Conditions. So we have several partners. The lead partners are the Public Health Foundation of India and the University of Leicester. And there are several other partners, including the Kathmandu Medical College, Hriday, which is health-related information dissemination of amongst youth, in partnership with the All India Institute of Medical Sciences, Delhi, as well as Jodhpur, University of Birmingham, University of Brunel, and University College London. The first question that we need to ask ourselves is, what are multiple long-term conditions of multimorbidity, as it used to be called very frequently? NIHR doesn't like the word multimorbidity because they work towards wellness and they want to call it as multiple long-term conditions. It's merely the co-occurrence of two or more chronic conditions. It is emerging as a public health challenge globally, particularly in low middle income countries. Why? Because people with multiple long-term conditions are more prone to rapid declines in physical and mental health, disability, severely decreased quality of life, early and high mortality, and most importantly, high healthcare utilization and costs to the country. This is a simple example of what is the burden of multiple long-term conditions in India. If you look at the blue circle, it shows something like 30% in the urban area at 49 years of age. As young as 49 years of age, these are data from the NFHS survey, which shows the prevalence of multimorbidity or multiple long-term conditions to the tune of 30%. And in rural areas, it occurs to the tune of 10%. But it substantially increases by the time we reach 60 years and 65 years. So much so, it's said that in high income countries, every other person above 65 years has multiple morbidity. The center will work in India and Nepal. And what are we planning to do? And why are we doing this? First, there's limited research on multiple long-term conditions because there's inconsistent definitions. Multiple definitions exist. There's limited data on common clusters, incidents, and the economic impact. There's limited data on care gaps. There's lack of integrated programs. You have vertical programs, not only in terms of communicable and non-communicable disease, but within non-communicable diseases, we have programs for cancer, for cardiovascular disease, and even within cardiovascular disease, we manage hypertension and diabetes separately. So I think there's a need for integrated programs. There's no national program to address multiple long-term conditions. So what should be our response? Our response should be to move from our focus on single disease, our emphasis on single diseases and single risk factors. We need to address this holistically. One of the important things that we address when we develop programs is the patient choices are never taken into account, and we need to take into consideration patient preferences. We need to address the continuum of care, that is from health promotion to prevention to rehabilitation. So across the continuum of health, that is even before people develop the disease, once people have developed the risk factors, once people have developed the disease, we need to do something for them. And we need to move the needle from illness, because medical profession has been illness centric, and we need to move that needle from illness to wellness. And there are several opportunities for us, because there is considerable redesign of health system both in India and Nepal. In India, we have the Health and Wellness Center concept, the Ayush Bharat Digital Health Mission, and several other new features that have been added on and are coming into play. And therefore, we have a great opportunity to influence these programs. Now, what is NIHR Global Health Research Center? The NIHR Global Health Research Center program funds research and partnerships between institutions in low and middle income countries and in the UK. These centers undertake high quality research and strengthen institutional capacity to undertake, manage, and disseminate high quality applied health research. It could serve as exemplars to both LMICs as well as to UK and other countries. So what do we plan to do? Our vision is to develop and evaluate interventions to improve care for people living with multiple long-term conditions in India and Nepal. Several features are going to be evaluated. This is going to be an integrated, technology-enabled, patient-centered, high-impact, equitable health system intervention, and it has 4 pillars to it. One is research, second is capacity building, third and most important is community engagement and involvement. And we have all this is interlinked through knowledge exchange, which we will undertake in these centers. So what is our research? Our research consists of 4 things. First is to assess the multiple long-term conditions burden and clusters in 2 locations, that is in Jodhpur and in Visakhapatnam. To identify the case mix and combination, there are 200 combinations when you look at 200 different diseases when you review the literature, but you have to have something which is meaningful, something which you can handle. Probably try and get the highest burden of 9 or 10 conditions together and design interventions to address those 9 or 10 conditions. We are planning to co-design the interventions by a consultative process And we will pilot the intervention and evaluate by a well-designed cluster randomized trial. It will be a pretty large trial so that it informs policy either way. In terms of research capacity strengthening, we will look at needs assessment to identify gaps in research capacity. We'll conduct what is called as research facilitation workshops, where we'll not only introduce the concept of research methods, but identify young and bright minds who will be selected for master's, PhD, and postdoc programs. We will plan to build individual, institutional, and environmental level capacity. This is just an example of how many people are going to be trained in the next 5 years. It comes to a total of 1,328 individuals to be trained across the public health system. That includes a variety of healthcare providers, researchers, and it will be a multidisciplinary group of people. In terms of community engagement and involvement, our partner Hriday is very strong on this area. They will engage with stakeholders, understand lived experiences, and co-design the intervention. We will identify a community champion. Who is a community champion? I need to explain that a little bit here. If we look at secondary care, for example, post a heart attack, there are 4 simple drugs, a few lifestyle advice like healthy diet, avoidance of tobacco, physical activity, etc., which can reduce a recurrent heart attack or death within the next 1 year by 75%. But when you look at the care cascade and ultimately reaches the patient, it comes to 20% or so. So how can we bridge this? How can we try and change this care cascade to improve to the actual level of benefit that we are likely to get? And that's where we believe that a patient who, an enlightened patient who could be trained actually to help other patients within the community in terms of improving their care, improving their compliance, facilitating their access to the health system and so on will help. And that's the trial that we are planning to do. We're also building patient networks to improve management and empower them. In summary, you might ask, what is new? After all, we know everything that works. What is it, that thing we are really doing? I think most important for us is that this evidence will inform and feed into the Ayushman Bharat program and the Ayushman Bharat digital mission. Co-designing of contextually relevant care model and health system interventions to advance continuity of care by involving multiple stakeholders, communities, patients, providers, and policymakers. That's a huge mix of people who will come together in terms of designing these interventions. We will build multidisciplinary research capacity to address multiple long-term conditions. Technology and science are reductionists because we're going to use several technologies. For example, we have an interoperable platform for telemedicine, which uses multiple technologies, frugal technologies, which can be scaled up. They're reductionist, but our solutions have to be holistic. The last thing is, it's not that UK is funding this program and India is benefiting, but it has to have a bidirectional benefit. It has to have benefit beyond India. We have to have South-South collaboration, and that's one of the things that we are looking at. We have a high-power steering committee headed by Dr. Rajiv Behel, who's the ex-officio chairman, along with Professor Margaret Cook, leading health systems researcher across the world. As you can see in the second line, we have patient representatives. They are part of the steering committee. This is very unique in the sense, normally we don't have patients as part of the committee. We do research for the patients, to the patients, not with the patients. And this is what we are planning to do here. And a very high-powered committee to guide and govern us. In terms of sustainability and impact, I think we are creating that critical mass of researchers, community champions, and research staff, and the government will be in the governance of the center. It will be a self-sustaining international center for improving management of multiple long-term conditions and disseminating outputs globally. So thank you very much for hearing me out. I started off with a Sanskrit saying, but I want to, being a Tamilian, I want to end with a Tamilian quote, which I don't want to say the Tamil thing, but the English translation is, we harbor a feeling of kinship for all places and all people are our own. So with that philosophy in mind, we instituted this transdisciplinary center. Thank you very much.
Thank you, sir. May I request Professor Kamlesh Khunti, Professor of Primary Care Diabetes and Vascular Medicine at University of Leicester and Director of the NIHR Global Health Research Center for Multiple Long-Term Conditions, to share a few words with us.
Thank you very much, Professor Paul, Professor Jodhpay, Professor Reddy, Professor Bal, Sylvia from NIHR, and my friend and colleague, Professor Prabhakar, and distinguished guests. All I can say is, wow, what a launch. We would never have a launch like this in the UK. So it's incredible to see such a number of dignitaries and the caliber of dignitaries here. So there's obviously a lot of excitement. I thought I'd just tell you a little bit about Leicester University. No one knew where Leicester was until we won the championship. Previously, I used to put a map of Leicester. It's 100 miles north of London, but now most people seem to know where Leicester is. But we have built a centre there similar to PHFI here. Professor Melanie Davies and are the co-directors there, and we work all the way from experimental medicine to implementation science with about 170 people in the team of various skill sets. So as I said, we don't just stop at research. We only think about the questions, we do the experimental work, we do the clinical trials, do the applied research, and then implement it. And this is why I think this collaboration is so strong, because this is what I've seen at PHFI as well. This is exactly the model that Professor Reddy and Professor Prabhakar have built over the many years. In terms of multiple long-term conditions, NIHR have really taken the lead in terms of funding in this area. There's no one else funding as much research as NIHR. And the reason I think we were successful, not only because of the world-class research that PHFI and our partners conduct, but also the leadership that we've had in University of Leicester in multiple long-term conditions. So we're the national lead for multiple long-term conditions for applied research collaborations. We lead the cross-NIHR collaboration for multiple long-term research. Obviously, there's this center. We've got the NIHR Global Group for multiple long-term conditions, and we're also the national training leads for multiple long-term conditions in the UK. So our commitment to this collaboration is not only co-lead, but we want to give a lot, and we want to learn a lot. As Prabhakar says, this is bi-directional. We are at a very early stage on research on multiple long-term conditions. We're going to be researching this for next 20, 30 years, because multiple long-term conditions is going to be the norm, not the exception. And so we're at an early journey, and learning together and bringing some of the findings here to the UK would be something I'd be looking forward to. The reason we are partners is we have expertise in primary care services and research on multiple long-term conditions, as well as a number of expertise that we bring from the University of Leicester on big data science, intervention development, complex trial designs, physical activity interventions, and healthy lifestyle interventions. We have a number of co-leads at the center who committed from University of Leicester, as well as match posts that the University of Leicester has given. And we have a number of operation people within the various work programs as well. We want to give oversight in partnership with the Public Health Foundation for India. We want to bring our epidemiological expertise in multiple long-term conditions and our expertise in staffing to support the various systematic reviews that will be ongoing. Although the launch is now over the 2 days, the teams have been working tirelessly, and we've already got groups working on the programs. We want to support with the CI activities and co-designing of interventions. We've been doing this in the UK for many years, but I've just heard over the last 2 days of the work that Monica and Radhe have been doing. We have expertise, just like you, on trial design, and again, this will be complementary, and research finding expertise. And we also, like yourselves, want our research to be implemented nationally, internationally, and make it into guideline recommendations. But the most exciting area of this is the capacity development. This is where I think this is such an exciting collaboration. It's not just to conduct the research, that's just part of it. But there's a huge amount of funding going for capacity development for researchers in India and Nepal. We have a Center for Ethnic Health Research. We will be giving a number of capacity building training, upskilling of patients. We've been using community champions, just like here, and patient networks to take up our interventions. One of the areas that NIHR commended us for was during COVID. We led a huge program of work because ethnic minority groups like Indians, like Black populations do not take part in research. But our Center for Ethnic Health Research led that work for NIHR to increase the number of participants coming from ethnic backgrounds. We have a community champions program, the patient networks. That's what really worked to get our participatory research. And we've developed a number of online skills and courses and skills that we want to bring here as well. In terms of the research capacity, this is the number of masters, PhDs, and postdoctoral fellowships that will be funded through this grant. So not only for PHFI, but Kathmandu University, AIMS Jointpur, and Radhe. Total of 50 individuals over the next 5 years. I think NIHR's commitment is not just for 5 years, there may be additional extensions as well. And these are the other areas of capacity strengthening exercises that we will bring. These will be all courses that are available from the University of Leicester for everyone who is associated with this program of work. And we have a number of short courses already started, the list of courses that, over the last 2 days that people want to access. And so again, this will be available to everyone associated with this collaboration. These are some of the courses that we deliver from the Center for Ethnic Health Research. And again, Leicester, many of you won't know, but Leicester is the first city in the country, in the UK, where the whites are a minority. 51% of Leicester is non-white. 40% is Gujarati, like myself. So some of the grapplings that you have here, we're getting that in the UK as well. So it'll be good to learn together on this. So we've developed a number of training programs, but I know you have a lot of training programs that we'd like to learn from as well. So with that, I'll thank you. I don't think this is the beginning. This is going to be a huge, long journey, and we hope that there will be longer term planning to continue this collaboration as a global center for many, many years to come. Thank you very much.
Thank you, sir. We are grateful to Dr. Sylvia Annie, Senior Global Health Research Manager, National Institute of Health and Care Research, to be with us today. Ma'am, may we request you to share a few words with us?
Good afternoon, distinguished ladies and gentlemen. Firstly, may I congratulate you on your successful bid for the NIHR Global Health Research Center's funding. We are so excited to be here because this will provide a sustainable platform for high-quality applied health research. And we are happy to see the members of the Center's consortium, Public Health Foundation India, with Leicester University as contracting organization, as well as All India Institute of Medical Sciences, Radhe in India, and the Kathmandu Medical College, Nepal. Additionally, I congratulate also the collaborators for this very important work. On behalf of the NIHR, I wish you success. And I know and I am certain that we will work together in achieving the core aims of the center. Now, from the NIHR perspective, what are we hoping to achieve with this funding? Number one, strengthen the low middle income country institutional capacity to undertake, manage, and disseminate high quality applied health research. And we've just heard about the numbers of PhDs, of fellowships, of masters, and so on that are planned. May I add that in addition to that, we would like to see the strengthening of the institution, the monitoring function, the finance function, the assurance function, as well as strengthening research career pathways. Again, with the Center's award, we are looking forward to engagement with local and national stakeholders to develop priorities and increase research uptake to inform policy and practice. Ladies and gentlemen, often there is a gap between researchers, those who make policies, and those who implement work on the ground. Recognition for the research team comes when the data is published in a medical journal. However, less attention is paid to how, and indeed, if research findings are made visible and accessible to key stakeholders who influence decision-making. So I wish you well as you go forward, interacting with policymakers, members of the public, patients, and caregivers. The NIHR looks forward to working with you on this journey, and the technical startup meetings began yesterday. We had very interesting discussions on finance, on assurance, on intellectual property, CEI. We also talked about communication and the branding for this work, and also on monitoring, evaluation, learning, and capacity strengthening. We really must make a change in our national NCD responses. And the question, ladies and gentlemen, is, after 5 years, what then? We fund, we have data. Does it change anything in policy, in our responses? But again, we are certain that this project will go a long way to improving policy and practice. In all of this, it is the voice of the community that must be heard as we work in partnership with research experts, policymakers, other civil society organizations, and the private sector. We wish you well. Thank you very much.
Thank you, ma'am. We are honored to have with us today Dr. Rajiv Bahel, Secretary to Government of India, Department of Health Research and Director General, Indian Council of Medical Research. Prior to this, Dr. Bahel was the head of research on maternal, newborn, child and adolescent health at the World Health Organization. So may we request you to kindly share a few words with us.
So distinguished colleagues, as Professor Kunti said, I think after 20 years, I'm seeing a launch of a research center, which is so grand and which has so many people here. And it's really very nice to see that. I want to start with, say, a couple of things. I think Dr. Prabhakaran has explained very nicely what this center will do, and Professor Kunti as well. I want to first congratulate the UK NIHR to have actually chosen to fund this center. And you have made a very good investment. Secondly, the congratulations are to the PF, Public Health Foundation of India, all the partners, Hriday, All India Institute of Medical Sciences, Kathmandu Medical College, and other partners, including, of course, University of Leicester, UCL, and I think there was another institution, that you are taking on such a nice, important issue, which is so critical, as we have heard, because not only are the risk factors for different NCDs common, but also people, it is from a people's perspective, it is the same person who is going to suffer from one or more conditions. And I think this is a very important thing to keep in mind, that eventually whatever research we are going to do must be useful for the people. And I think this will be indeed very helpful for the people of India. I also want to congratulate Professor Reddy, as Dr. Paul was saying, to have actually lit this lamp of PFHI so many years ago and have led this along with Dr. Prabhakaran and stalwarts like Professor Tandon to actually bring to attention the public, to public health, actually, the non-communicable disease prevention and management. On behalf of ICMR, the only thing I want to say is that we see this as a very close partnership with not only the center, with not only all the partners, but across for a big research initiative in India. As part of that initiative, we see this as a very important hub. And we would like to see that research initiative that works on prevention and management of non-communicable diseases much bigger than what we have been able to do so far. So I think this is very timely from that perspective. Finally, the other thing I want to say is that research capacity in this area, we need to really go beyond the big players, which we already have here, the Public Health Foundation, the All India Institute of Medical Sciences, New Delhi, etc. We need to really bring this research capacity to 100 institutions in this country, not just a few institutions that will be doing this. It will not be possible for a few institutions to lead. They can be leaders, you can be mentors, but eventually it is when it becomes a mass movement, when we see this type of research happening in multiple health institutions, almost all medical colleges in this country, that it will become something of note. And finally, what I really like about this is you're not only doing the research, you're not only building research capacity, but from the very outset, you are looking at how this research will be used for the good of the people. So it is by definition outcome driven. And that to me is the core. You are not only looking at the problems and defining who has the disease or who has multiple conditions, but you are finding potential solutions, and then you are making sure that those solutions will be taken ahead. And there also, I give, along with, I think Dr. Paul will be even able to give more assurance on that, but we will make sure that the government of India considers this evidence that comes from not only the research studies of this center, but from an entire research enterprise in this country, to be able to use that for the people of India. Thank you very much.
Thank you, sir. May I request everyone to welcome on stage our chief guest for today, Professor V.K. Paul, member NITI Aayog, Government of India. Professor Paul has served as the head Department of Pediatrics at All India Institute of Medical Sciences, New Delhi for nearly a decade. He leads the health, nutrition, and HRD verticals at NITI Aayog and has played a pivotal role in the formulation of key initiatives, including Ayushman Bharat PMJ, Ayushman Bharat Health and Wellness Center Scheme, and Poshan Abhiyan.
Namaste, good evening. Respected Professor Sanjay Zodpeji, President, Public Health Foundation of India. Respected Dr. Srinath Reddy, my friend, philosopher, guide, mentor, and one who has given leadership to NCD in the nation amongst many other contributions that he has made. My teacher, Professor Santosh Bhargav sir, Professor Kamlesh Khunti, Dr. Sylvia N. Dr. Rajiv Bahel, distinguished colleagues from India, Nepal, UK and other countries, PHFI family, and friends. I joined Dr. Bahal in congratulating the collaborators of the initiative, very impressive research project that we are launching today, and thank the funders for having reposed faith in the capabilities of the Indian collaborative team. Thank you for doing so, because this is an initiative much needed at this point in time, in particular. I come from the child health background, to an extent, child maternal health background. And I always felt that when pediatric interventions, child and newborn interventions were placed into programs and WHO guidelines, we were tasked as a fraternity of researchers, we, not individual, but we, that we had to demonstrate the effect of those interventions on mortality, on change at population level, ORS zinc, for example, ARI algorithms, kangaroo mother care, and so on. For real reasons, practical reasons, scientific reasons, when the NCD programs started to get rolled, at least in country like ours and others, the research base in terms of solutions was, I always felt, not of the same kind. Problem assessment, yes. Prevalence, yes. Disease burden, yes. Correlates, risk factors, yes. But when it comes to intervention, to change the processes, outcomes, intermediate outcomes, I think we have lacked, we don't have the same kind of rigor. I can accept the fact that things like mortality cannot be assessed, but then even otherwise, the body of research available to back the aspirational programs that we needed to do has been relatively weak. For at least hypertension, we have more clarity with India Hypertension Control Initiative. We know that if you do certain things like this, there is a 46% control at population level in hypertension. I don't know whether we can say the same thing for diabetes. I don't know what to say in a similar way for cancer cervix. I don't know, for mental health. So in that sense, to be taking a journey to look at public health issues related to chronic diseases in an integrative way is much needed, much needed. So I congratulate you. I like to make, from the perspective of policy enabler, but also as one of us, I like to make 5 points. I heard from you first that you will go into the field and you will assess which comorbidities are, and then develop an intervention package. It's correct, it's fine. I would urge you to also look at a parallel approach, which you must be doing, but let me say, because I didn't hear it. In the national program related to chronic diseases and cancer, we have a complicated name for it. There is already a family of illnesses which have been prioritized by the government, by the people of India, by the scientists of India, in fact. I like you to keep that in mind, that you're not starting from zero, number one. Number two, we are extending that paradigm from hypertension, diabetes, cancers, fatty liver, to kidney and liver disease. So take it as a given as well, because that's also based on information. The whole idea is to cut down the time when you can provide inputs to the policymakers. 5 years is too long. 2030, we are expected to reduce preventable mortality due to chronic diseases by 1/3. Would you like this research initiative to be helpful in that regard? Take a call. If you wish to do so, then may have to do certain things in slightly innovative way. I leave it to your judgment. This is just a suggestion. Kidney and liver must be included. Let me repeat that. Mortality due to kidney diseases, global burden of disease, again, which I'm so proud, PHFI houses it and nests it, is around 200,000 deaths, 210,000 deaths, 2018, what I remember. Diabetes mortality, Delhi's can be much more, but the diabetes mortality is 254,000. Liver mortality is 225,000. The point I'm making is, even when we are looking at diabetes being part of our national program and trying to roll out with great difficulty with the resources that are available, these other diseases are waiting to be embraced in our program. And we have very little information and research and, of course, the potential pathways to address. Of course, we have experience of diabetes. We have experience from how to address from Dr. Nikhil's work, your work, how to handle. But then let's not lose time in applying what we have learned on some of these diseases. So I want you to remind you immediately that these diseases, and then of course you integrate them in a certain innovative way, that's a given. Having said that, I also feel how you will integrate this with cancer. I don't know. I'm excited about that. How do you bring that? I don't know whether chronic disease is also a severe mental disease. I don't know. I also don't know whether geriatric, this as a fundamental overarching problem underlying this, as we heard from the data, how will that come in? But of course, I'm sure you'll find a way forward on that. The point I'm making is this discussion must be happening, but I want to enlighten the audience here that some of those thoughts can be taken forward. My second point is the intervention must be tailored, not tailored, I should say, aligned with the health system that we have. Some of the initiatives from time to time, including this in the space of child health, maternal health, have been in isolation, or mental health for that matter. We can push the frontier, which we must, but we must also use the opportunity that has been created. And there, I like you to keep in mind that the primary care platform for India is health and wellness centers under the Ayushman Bharat. There is no other platform for the time being. I'm sure you'll develop interventions which get aligned to this. If not, then I think we already have an issue about it. Of course, it can be strengthened. If there's a need for another worker, talk about it. But that platform has been set to meet the emerging needs in the medium term. 150,000 health and wellness centers are expected to be operational by the end of this year. I think we are at about 130,000 plus already. And I like the distinguished colleagues from abroad to visit them and see how they function, what the thinking behind this. We have a mid-level provider, again, recommendation that came from Dr. Reddy's led initiative under the HLEG. Mid-level provider is there, who is typically a graduate nurse and can do a lot. So remember, it will be aligned with that. I know, but I just want to emphasize that it's made sure. Also remember that there are pathways of referral, which we will use. And also you may like to remember that there are patients who will go to private sector because that's how it happened and how you like to align with them. I like us to remember that those who are covered by the national health assurance system, namely PMJ, should be placed into that channel and to be seen that they can access care through that. And this is 40% of India, 500 million people. So technically use this, the way you will offer us solutions to channelize them to receive services at secondary and tertiary care in the inpatient setting, should that need arises through the PMJ system, and facilitate and create pathways for them to access this care, whether it is for cervix cancer or breast cancer, or for that matter, for diabetes with complications. I no clinician, but we have watched the developments from vertical programs to more system level things. In the MDGs era, what was done conceptually was an approach that could be termed as a diagonal approach, to use Julio Frank's paradigm. What we did was that for, let's say, maternal, newborn, child, reproductive health, we package the intervention, which we thought will address MDGs 4 and 5, then thought what health system is required around it. Now, India, in a sense, has a little bit of, we are in the gray zone, in the sense that we as a nation are aspiring to have an all-encompassing health system to be ready well in time to deliver a developed nation by 2047, which means India's healthcare system has to be like a developed nation health system by latest by mid-30s, so that we are enabler of achievement in terms of the overall development of India at that table. So one tension is holistic, and that's the way India would move and should move. Why not? People have aspirations to have their stents put and knees operated, as well as provision for ORS and zinc in the home settings. But within that, for the priorities that you would address, certainly pathways can be ensured to make sure that there is a clear focus and sufficiency of the health system resources around that. So think about how this model would go, but clearly an integration of chronic diseases, the way you have envisaged, is truly laudable. My third point relates to the use of the Indian system of medicine, the traditional systems of medicine of India, wherever they fit in, to the extent that we believe they are compatible with evidence and acceptance at the community level, whether it is yoga, whether it is certain Ayurveda products. If people accept, it is their choice. If it comes from that side, to the extent that we should be aligning them. We are not saying mixing them in terms of mixopathy, but we are saying, as a policy of the government, think about aligning them and create a comfort zone where citizen doesn't feel conflicted and doubtful when he or she chooses to be here by the other system. Because the way forward for India is clearly togetherness, integrative, not mixing. So we like us to respect that paradigm as we move forward. My fourth point relates to the issue of capacity development. I'm taking a leap from Dr. Bahal. I like us to keep in mind that the geographies where you are. Jodhpur has a All India Institute of Medical Sciences. There must be more than one government medical college in the vicinity of Visakhapatnam. Please involve them and build capacity of high quality research, learning, and of course, they'll become your force multiplier for action as well. So at least for that and beyond that, because if AIIMS Delhi is in picture, surely others strategically beyond us, capacity development should be taken care of. My last point would really be that when you present analyses for policy in intermediate stages, what would be helpful, perhaps not very difficult to do, iteratively as you sharpen the intervention packages, their efficacy, etc. Tell us how this conundrum of 1/3 premature mortality reduction by 2030 can be achieved. So let's say hypertension, diabetes, Punjab model, coupled with IH, whatever, India Hypertension Control Initiative. What would this yield if we take it to scale? What would this mean if the HPV vaccine comes in time? So iteratively, if this comes from the ground based on research coupled with risk analysis, upgraded data that you already have, program-based data, this will give us confidence that we are on track to address and achieve SDGs if possible. Otherwise, we as a community still have really not articulated this, something that we used to do in MDGs quite often, that if you do this, we will get this much reduction in mortality. In fact, that's another aspect which we scientific community should talk about. What will it take in terms of coverages with high quality to achieve 1/3 premature mortality reduction in NCD space by 2030? What are those 3 things to be done or 43 things to be done? I don't think we as a community know it. Can you help us sharpen that? Then government will think about resources. It will make a case for certain decisions to be taken, certain priorities to be repurposed. So I like us to see this initiative, a great initiative, timely initiative, in the light of that journey. And I request you to kindly align as much as you can with the, the rapidly evolving policy paradigm and program paradigm in relation to non-communicable disease. It's rapidly changing because we are now suddenly in a hurry. 2015, MDG is achieved, maternal mortality less than 100, we'll achieve 70 MMR, IMR will be achieved, NMR will be achieved for 2030. We are in the safe zone. We can see it happening. We don't see it happening for NCDs. I don't know if we like to know and how this can rapidly plug into this. Let's not go into a mode of, something eventually that becomes not so useful, from becoming highly useful and highly topical, highly timely. And last but not the least, we'll be very delighted to support from NITI Aayog, from other arms of the government, I'm sure from the Indian Council of Medical Research, how we can come together for dialogue as we move so that it is connected, but even more than that, if other facilitation is required. Thank you very much. Grateful. Good. Thank you.
Thank you, sir. We will now begin with the panel discussion on health system strengthening through research, community engagement, and capacity building to address multiple long-term conditions, followed by a brief discussion. May I request Professor Zodpe, President, Public Health Foundation of India, to kindly welcome our eminent speakers. Professor Srinath Reddy, founder and past president and distinguished professor of Public Health Foundation of India, to moderate the session. Our speakers, Dr. Rajiv Sadanandan, Chief Executive Officer, Health Systems Transformation Platform. Dr. Sylvia Annie, Senior Global Health Research Manager, National Institute for Health and Care Research. Professor Nikhil Tandon, Head, Department of Endocrinology and Metabolism, All India Institute of Medical Sciences, New Delhi. Mrs. Jyotsna Govil, Vice Chairman of the Indian Cancer Society, Delhi branch. Dr. Ajay Tandon, Lead Economist, World Bank. Dr. Monica Arora, Executive Director, Hriday, and co-applicant. Dr. Cherin Burgess, Regional Advisor, Non-Communicable Diseases, World Health Organization, Southeast Asia region.
Good evening. In the Indian philosophical and astronomical tradition, there are reported to be 7 sages, or the Saptarishis. We have 7 panelists today representing that tradition. And I'm supposed to be the one moderating the discussion. But many of the questions that could have been posed have already been posed by Professor Vinod Paul. So it is with a great sense of redundancy that I start this panel discussion. Nevertheless, since I've been assigned this role, let me start by asking Dr. Rajiv Sadanandan. You have been an administrator in the Indian Administrative Service. You've been health secretary. You have held so many other positions in other sectors as well, which impact upon health. And now you're leading the Health Systems Transformation Platform, engaging with governments across the country and also with other agencies. Given the fact that health systems in general have had a very siloed approach because of vertical programs, and even within those vertical programs, they've had limited attention to non-communicable diseases or long-term conditions of chronic duration. How do you think that this particular research endeavor is going to inform and influence our health systems to become much more integrative?
Professor Reddy, if I had the answer to that, my life would have been a lot easier than what it is now. One of the stories that I tell the governments that I interact with now is that if Kerala knew what we know today, because Kerala has a hypertension rate of 30% among the adult population, 20% diabetes, and 67% is a rate among people of diabetes for people aged above 65. You don't even want to hear our dialysis rates. So what I tell the states is, look, the states that the high focus states that we work with us, it may not be possible for us to come up with the evidence now, but what we can do is look at what happened to some of the other states that preceded you on the epidemiological transition curve and learn from that now. The problem is that it's difficult to get much of an audience for that kind of a plea, because the response, the health secretaries will be very, very, very polite with you, but the directors will come and say, sir, we have to deal with IMR, we deal with MMR, this can wait. So the possibility would be that if we can generate evidence to show, one, that even your MMR and many of the other conditions are impacted by NCDs, and I don't think many people know that. And also to demonstrate how there are techniques available that can control it. But I think one of the biggest problems that I used to face as an implementer is we do not look at the behavioral aspects that drive people's compliance. I'm talking about the high social discount of the future that happens when the condition is not salient. That's if I'm hypertensive, I don't know, it's not costing me a problem. So why should I go on to do something which is unpleasant for me, which is a drug? Why should I take a drug? So I think the cultural and behavioral dimensions, which could be one of the areas that possibly we could look at, which is also which of the providers who don't consider it that important, of the policymakers who don't consider it important for various reasons, and most importantly, of the patients who do not consider it important for various reasons. It's easy for us to take a linear approach and say, if you do this, this will happen. But that's not how it works in the real world. So my request to this project would be, drop the linear approach. It doesn't work. I can assure you that because I tried that. Understand the complexity and then see how that the various dimensions can be addressed. I hope.
Thank you. I think you've brought in the most important message in terms of why linear models of research are very incomplete in investigating a problem and are providing inadequate solutions. And if anybody wanted to be reminded of that, COVID-19 has given us ample evidence how linear models have failed. And certainly complexity science needs to be integrated. And the fundamental foundation of complexity science is multidisciplinarity. And that is where I think we'll have to bring that in with the agility for self-correction as we monitor the progress of the project. I'm sure the investigators would be looking at that. Dr. Sylvia Anning, you have provided an opportunity for this research to be undertaken in multiple countries, addressing a problem related to multiple long-term conditions, which has been mostly in the penumbra of health research, hardly ever really looked at. But what are your expectations of this? And how do you feel the evidence gathered here is going to inform the performance of health systems, not only in the participating countries, but elsewhere in the world through portability of that knowledge?
Thank you very much for the very interesting question. NCDs kill 41 million each year. It's equivalent to 74% of deaths globally. And of all NCD deaths, 77% are in low and middle income countries. It's alarming. And that is why, after scoping, we decided that let us fund NCD research. And that is why we are here today with the Centers Program. I take you back a bit. We had about 40 applications. Two-stage process. So then the 40 was whittled down to about 20. And then the 20 came down to about 10. Then we interviewed the applicants, and now we have 5 centers. We are excited because when you look at the coverage of the 5 centers, it's remarkable. We have a center in West Africa, Ghana, Burkina Faso, Niger. So again, drawing in the Francophone countries. We have a center in Colombia, and that straddles Guatemala and Bolivia. We have a center here, this one we are talking about today. And then there's another center in India with the George Institute. I'm sure I haven't mentioned 5. I've probably done 4. So Jessica will probably have to remind me what the 5th one is. But it's just to show you that this is a huge investment. It's 10 million pounds over 5 years. And your question is, what are our expectations? Firstly, we recognize the importance of policymakers in national NCD responses. Therefore, if we are to make a change in our responses, we are looking to see that the centers will engage policymakers. For us at NIHR, there is little value in having a lot of data, a lot of research, but nothing changes. If you go to communities, after 5 years, they are still not coming for screening. The advocacy hasn't been targeted enough. They don't want it. So we are looking at research that will result in change. That will result in a better national NCD response. And again, the previous speaker said, aligned to the national response, not something running vertically. So these are some of our expectations. We want to see community engagement. Community engagement is not just, ladies and gentlemen, engaging community. You want to engage to have a result. So that's important. And again, with the 5 centers, we want to encourage synergies. So for example, Public Health Foundation India is talking to Javeriana University in Colombia. They are learning lessons. They're training masters and PhDs. They're looking at what is the role of faith healers in NCD response. When do you enter a community? Do they want you there? These are the issues that I think will make a difference for us for the National Health NIHR. So we work in partnerships, but there's a gap we've noticed, which I may quickly share with you. The gap is that I think at NIHR level, we should move towards partnerships a bit more. We can't do it alone. So where you have NCD, chronic alliances, NCD, civil society organizations, we work with them, we strengthen the partnership, and then we provide the funding. So partnerships will be key going forward. Thank you very much.
Thank you very much. Indeed, the kind of questions that you have raised as the questions that will be addressed by the various centers across the world are truly going to inform and enrich the delivery of health services as needed in the real world. And that is what really matters. Now, in a lighter vein, may I say that with the rising burden of non-communicable diseases all over the world, and not only in this part of the country, but also in a number of other low and middle-income countries, may we look to NIHR for multiple long-term grants?
You may.
It's a legal funding. Professor Nikhil, you have been a very active clinician looking after a number of chronic diseases. You've also been a researcher generating knowledge and trying to translate it into policy and practice. How do you think this particular research endeavor is going to alter the life of patients with multiple chronic conditions? And how is it that the products of this research will find uptake among policymakers and practitioners?
Oh, thank you. Just change the tense of your, I am still clinically active.
You have been. I said
there was a bit of a have been, so I thought I'd best clarify that.
Have been is the present continuous tense.
I withdraw.
So don't be tense. Don't be tense.
Lest I find that by the time I leave the room, I've stopped being a clinician, which worries me. Thank you. No, so as clinicians, you and I and several others in the room have managed to sort of influence single individual outcomes, right? And maybe over a period of life, since we see a lot of patients, that's several thousand, but that's really the drop in the ocean. And therefore, research like this becomes very important because we need to, as I think Dr. Paul was mentioning and Dr. Rajiv Bahl also mentioned, just like you can't consolidate research in few institutions, similarly, you can't consolidate, management at just tertiary care or at specialist level. And a large proportion of non-communicable diseases and chronic non-communicable diseases must be managed at primary healthcare level and are manageable, and not only must be managed, are manageable at primary healthcare level. We just have to create the appropriate treatment workflows, the appropriate screening and risk factor assessments, and the sort of appropriate intervention models so that they can be delivered at that level of care. And we've been informed without doubt that at the moment, our target must be at the health and wellness center. And to that extent, I think it is critical that research like being planned by this project needs to involve multiple conditions which are likely to belong to an individual. And I deal with diabetes, and invariably the person with diabetes has hypertension, may have osteoarthritis as they go along, may have clearly depression because of tackling their diabetes. So that's already 4 conditions. And each one of this, we will manage the diabetes, maybe a little bit of the hypertension. We don't manage the osteoarthritis, and we don't even think about the depression. So clearly the understanding and that at an individual level also you are dealing with multiple issues. You're not looking at them because you don't, at tertiary level care, you feel it's not your obligation to do that, but at primary level, it has to be done. And therefore, I think that becomes a very critical thing. I'm just going to add two more aspects to something, and you would perhaps take most of the credit for the national program for NCDs to be a national program for NCDs. And I remember maybe a dozen years ago, there were people who were wanting a national program for diabetes, a national program for heart disease, a national program for something. And I think it's predominantly efforts made by you, which ended up in at least having a consolidated NCD program. And I must put it on record that the fact that we have an NCD program and not 16 different chronic diseases as individual verticals perhaps rests largely on Dr. Reddy's efforts. But in verticality, the other thing which we have to appreciate, and that's again something which you and I, and I'm sure several others have discussed, that for NCD care, NCDs are too critical to be left to one ministry alone, which is the health ministry. I'm not saying that the health ministry doesn't do a great job with it. Of course, it does a good job, but the influencing factors for NCDs, the risk factors and interventions require multiple different ministerial interventions. And I still remember the ICMR made a valiant effort to do that once, called for a meeting for multiple different ministries who grudgingly sent perhaps the lowest available bureaucrat on that date for that meeting, and that died its own death. The next effort was perhaps a little bit better because it happened soon after the UN high-level meeting, and we had a higher traction and buy-in, but again, it got lost. I mean, if I'm telling somebody to do physical activity and there are no walkable spaces available, the health ministry can't do anything about that. If I'm advising somebody to eat the right foods, but the right foods are perhaps more expensive than the wrong foods, again, the health ministry cannot do something. So I know this possibly goes beyond the scope of the particular center, but it's important to understand that it's not merely verticality within the health system space, but there's also verticality which happens in ministerial levels. And we need to get much more cross-connectivity to ensure that this really translates into something. And of course, and I think the issue about community engagement is critical. People have many more important things to do. And I have a colleague endocrinologist who has this lovely slide about an interaction between a patient and the doctor's telling them, you must do this. And what keeps popping up in that patient's mind is, hang on a sec, did I switch off the electricity before I left home? The next thing was, oh, did my daughter take her homework along with her in the school? So really the competing influences in a country like India are tremendous. And we need to sort of supervene so that we manage to take care of those. And I'm just, this is entirely for Prabhakar and Kamlesh, so that, we're just telling you just a few more things you have to do, not merely restrict yourself to managing diabetes and hypertension.
Thank you. Given the kind of segmentation that takes place on policy level and the fragmentation that takes place actually in the delivery of services, clearly, if one has to look at how to unify all of these, the community is the place where individuals and families experience all of these conditions, either each individually in their lifetime or as families together. So it is there that this unification is much more visible and also aspirational in terms of need for services. So that brings me to two people who are going to be talking about the community. One is Mrs. Jyotsna Govil, who is the chairperson of the Indian Cancer Society. You have been representing and also articulating the voice of people with lived experiences, people who have had chronic conditions or long-term conditions, and try to ensure that their perspectives are adequately reflected in policymaking as well as program design. So would you like to tell us about that and how you feel that this research should be directed?
I don't think so.
Thanks. Yes, thank you for the opportunity. I come to these meetings as a learning experience. I listen to all of you. Some of my questions are answered, but mostly they're not. So I want to ask, do you realize that patients are the bottom of the heap? You might have a hierarchy of general practitioners, specialists, super specialists, researchers, policymakers, but the patient never features there. They're always at the bottom of the heap. When I walked in here today, Dr. Paul asked me, so what are you doing about cervical cancer? And I had the pleasure of telling him, Dr. Paul, we at the Indian Cancer Society started a program of cervical cancer screening in the year 1999. It was 10 years before your vaccine appeared. How many of you even know about it? It's called Pap Test Delhi. It's been running without a break every single year. I don't know that any of you have even heard about it. It's our fault. Yes, Sunila, I know. You have, because you've been... Yeah, that's right. Yes. So thankfully, one person in this room knew about it from the beginning. We don't have money to spend on marketing, on publicity. We are an NGO. We get no help from the government. We look to people, to individual donors, to CSR projects, and I hope now, Sylvie, to you. Okay. To get our programs moving. I want to remind you that not so long ago, there was what do you call it? A feature of the family physician. Yes, we didn't go to specialists. We went to the family physician. He sorted us out to the point that he told us what was important, what needed to be done, what foods to eat, and what else to do. We didn't waste a specialist's time on these things. And when we go to the hospitals, my experience is of two major diseases. One is cancer. I head the Cancer Society in Delhi. The other, more painful to me because it was a personal problem, was that my husband had dementia. If you think cancer care is lacking, please look into the care for the mentally ill. Some of the well-meaning, I give them the benefit of the doubt, well-meaning doctors. One who told me, admit your husband in our hospital, don't come near him for 10 days, and we'll tell you what is wrong with him. Well, I know what is wrong with him. I'm not going to turn my husband into a raving lunatic by leaving him in your care for 10 days with no familiar face. Do doctors think about what they are saying to the patient or to the care provider? Do they realize how hurtful it can be? A casual remark, not with any bad intent. I never attribute that. Why? You've been talking about comorbidities, multimorbidities, and I must thank Dr. Prabhakaran for a wonderful article, which is in our folders as well. You know, I'd never heard the word comorbidity till COVID came along. We knew side effects of treatment. We knew that our patients went in with one complaint of a cancer. They came out with diabetes, hypertension, osteoporosis, dental problems, hearing problems, sight. Do you think of that? Dr. Tandon, you just said that when they come to your clinic, you're looking at diabetes. You know very well they have other things. In your clinic or alongside it, is it not possible to have other people sitting around, someone who deals with these problems or at least is able to fix appointments for these people who have come 800 miles, 900 miles away from Delhi? They have left their homes, they've left their children, they've left their elderly parents. We need to think about what the patient needs. I'm delighted to hear about primary health centers. I'm delighted to hear about health and welfare centers. But I was talking not very long ago to a doctor, a local doctor from a little town near Patna. And he told me, these doctors will come and they will go. Patients won't go to them. They'll come to me because I know the local conditions. Luckily, he was not a quack. He was a qualified doctor. But why can't we provide basic training to the people who we send out to these health and welfare centers in the boondocks around India? We have ashas, poor, overworked women who are looking at everything from delivering a baby to telling someone that he's on his deathbed. We need to support them. We need to strengthen them. And we need to make sure that they deliver to the population what is required. I invariably make a lot of points. I talk too much, so I never get through them. But today, I hope you'll give me a moment more. You need epidemiological evidence, a longitudinal screening record to make sure that your research works. I'm not a researcher, I'm not even a doctor, but I think this is important. If you don't know what is causing certain disease in a certain area, how do you plan to treat it? I think it is necessary to integrate screening data with hospital data. Very often I feel that hospital data is only a record of how many people came in and how many people died. We are not looking at that. We are looking at how many people came in, who come back to us year after year after year to tell us what their problems are or if they need any help. We are a small NGO. We look after awareness. When COVID came, we realized that we couldn't go out into the community and talk to them physically. So we created a site on Swayam. Many of you will know the Swayam platform. It's a self-learning platform of the Government of India, Ministry of Human Resource Development. If you haven't heard of it, please look it up. It's a wonderful platform. It gives people like us a voice. We created a course on cancer fundamentals. And in 2 years of COVID, we have 10,000 students doing it. We don't charge anything for it. Only if they want a certificate, then they pay the person who certifies them. This year, we have started a course on faculty development. The new education policy came in and we jumped at it. Because for the first time, the Government of India was saying, beyond your course, What else have you learned in your 4 years at university? So we developed the course for faculty across the country, again on cancer fundamentals. Each member of faculty brings in 5 interns. Those interns have to give us a full program of how they're spreading the word in their areas, looking out for resources. Where are the dharamshalas? Where are the chemist shops? Where can families stay when they come from outstation? It's a lovely program, and I'm delighted when I go to colleges here in Gurgaon and Faridabad, and the excitement that is bubbling over there is really encouraging. So now I only have my last point. As you said, there's no point in research in whatever unless you have a solution. You are looking after sick people. I want survivorship clinics. You're not in the job of killing people. You're in the job of curing them. But when they have survived and they come away from the hospital and the next year they have a little problem with their sight, maybe with something else, whom do they go to? I want survivorship clinics everywhere. And in particular for children. You have pediatric clinics, but children grow up. They become adults. Who's looking after them? It's time to think of a bridge between the child clinics and the adult clinic. And finally, we suggested to the NHRC that when a cancer patient, because that's our area, when a cancer patient needs follow-up and the oncologist complains, they never come back. They don't come for follow-up. How are we supposed to keep them well? Well, if you had a family that lived that far away, you had elderly parents, you have children, you have no servants, and all that happens when you come to the hospital is that somebody looks at you for 5 minutes and says, "Haan, theek hai, wait, dawai chalti rahe." Let the same medication carry on, go ahead. They feel, what the hell, why are we coming? I think that if you enabled those health and welfare clinics and the doctors to look out for whatever it is you're looking for in the main hospital, you're not sending everybody for an MRI or a CAT scan or whatever else. You're only examining them. You're asking 2 questions. If that person is lucky, 3. That's it. So please tell those people at the primary health centers what those questions are. And if they find something that is alarming, then send them to you. We are not trying to displace any doctor. We believe that we are all necessary. From the policymaker to the patient, we are all necessary. We are all in it together. And we need to work that way. If I can make one last point, because I spotted Dr. Behl sitting here. Dr. Behl, please get the government off its backside. 10 years ago, a vaccine, sorry.
I don't think he can do that.
Can you do it? Who can do it? Whoever it is who can do it, please do it. 10 years ago, a vaccine came out which could save hundreds, thousands, millions of women from the pain of cervical cancer. Who put a spoke in the wheel? Not the patient. Some politician for electoral gains. Some doctor, opinionated, egoistical, who said, oh, but we need 10 years of data. Yeah, sorry, I'm winding up. I don't like pointing fingers either. But please, I go back to my main request. Please get the government off its backside. Thank you.
Well, if you have to get somebody off the backside, you have to light a fire under the chair, and the community is best positioned to do that. But I think your messages are very clear that you, even if specialists are important for making the diagnosis and deciding the initial treatment, long-term care, which is continuous, connected, and compassionate, is best delivered at home or close to home. And therefore, primary care, with all its participants in care delivery, are going to be the important element, and particularly primary healthcare teams rather than just individuals. And I'm sure you are the kind of person that our MPH students would like to listen to, and I'm sure Professor Zodpe will invite you one of these days to talk to them. But Dr. Monica Arora, you have been working with young people, but you're also now dealing with non-communicable diseases, not only in terms of a life course prevention approach, but also looking at how NCDs should be prevented and controlled at the global level as the president-elect of the Global NCD Alliance. But clearly, community engagement is pivotal in whether you're dealing with health promotion in the young or chronic long-term care in the adults, or even in children for that matter. So how do you feel that this particular research project is addressing the community perspectives apart from trying to cater to their prioritized needs?
Thank you, Dr. Reddy. And my job becomes easy with Mrs. Govill's opening remarks. I would only like to emphasize that this particular center would be focusing on meaningful engagement of people with lived conditions. And when I say meaningful engagement, it is that they are brought to the decision-making tables. It's not that we talk to them in the community and we do awareness for them. We have to make them a part of the health system. And that is what we will be aiming towards. We will be selecting community champions from the perspective of equity, diversity, and at the same time, inclusiveness. So we should be able to reach the marginalized population. It is very easy to work with people with the lived conditions in the urban areas, but when we go down to the rural areas, that is where we see challenges. Also, one example I would like to quote, when we started community conversations with the people living with NCDs, we asked a person with diabetes, what medication do you take? And the answer in Hindi was, ek subah safed goli leta hu. This is urban setup, educated businessman, not knowing the name of his or her medication. So that is where we felt as a public health experts, public health community, we have failed in empowering people with lived conditions. How can we expect drug adherence? How can we expect regular follow-ups, monitoring, when they do not understand their condition? They think the onus is on the doctor who's treating them. Similar condition, when a doctor is approached by the caretaker of a patient asking, what has happened to my family member? Obviously, they're concerned. The answer is, even if I try to explain you, would you understand what is myocardial infarction? This is so humiliating. For a caretaker, he would never ever question what the treatment pathways are. They will not be involved in decision making. So we realized we need to work on both ends of the spectrum, empowering people with lived experience to come to the level of understanding the condition and ensuring they do not have the next episode, and not just leave it there, but also work with the health system, with the physicians, with frontline health workers. We know there is paucity of time. They have so many people to look after, but can we work out, make community champions of people with lived experience, and they become this bridge between the health system and the community. We empower them and they become the navigators for new patients who come into the health system. They navigate them, they guide them on drug adherence, lifestyles, And as a support group, we will be able to have 30 community champions who will under them have, each one of them will have 100 patients. So a patient support group of 300 is what we will begin with. So I would just like to conclude that we aim at adopting the UN SDGs transformative strategy of leaving no one behind. We will be including people with lived condition, their caretakers, frontline health workers, faith healers even, because we will be empowering them how to be supportive in the community and working with every person who has that power dynamics of influencing their access to health and wellness centers. And our ultimate aim would be if patients are seen as patient experts as a stakeholder on the National Multi-Sectoral Action Plan. It has community, it has CSOs, but it does not have people with lived condition as a stakeholder. Thank you.
Thank you. Dr. Ajay Tandon, the World Bank has also been dealing with multiple chronic conditions as a priority. Of course, it took a long while for the World Bank to recognize that NCDs exist as a health priority. So, but between 2000 and 2007, the situation changed, and I think World Bank has become one of the biggest votaries of why NCDs must be accommodated much more prominently in health system for healthcare delivery. In terms of multiple chronic conditions or multiple long-term conditions, as a leading health economist, how do you see the economic impact of unaddressed conditions? And what would be the economic benefit of the health system providing the kind of optimal care for their health and well-being and productivity by restoring functionality?
So thanks very much, Dr. Reddy. And yes, you're right. There was this, I think previously there was also this perception that NCDs was something that affected the rich rather than the poor. And I think it took a lot of research and a lot of measurement to demonstrate that that's not necessarily the case. And many times, many of the risk factors are much more prevalent among the poor rather than among the rich, and a lot more undiagnosed NCDs occur among the poor. And so one consequence of that is really in terms of productivity, right? So you know, I'm not a medical doctor, so we don't necessarily think in terms of morbidity and mortality, but we do think in terms of economic productivity and also the costs of having to seek care. And so in fact, the World Bank has recently initiated a project called the Human Capital Project, which includes tracer measures. In terms of NCDs, it's the probability of those at age 15 to reach age 60 as one of the key indicators. And the goal of the project is really targeting not the medical fraternity, it's targeting ministries of finance so that they think of health investments as investments in the human capital of a country, just as you would think of education or infrastructure investments. This is also part of the infrastructure of what contributes to economic growth. It contributes to income generating potential. And I think Dr. Prabhakaran also said, you know, NCDs are occurring more and more at younger age groups, and where, you know, traditionally people are meant to be in their productive age. So, you know, raising awareness of the consequences of that, of the economic consequences to the broader dialogue is key. But also the way in which a health system is financed also matters, not just for improving health, but also improving economic outcomes. We've talked a lot about the demographic transition, the epidemiological transition, the nutrition transition, but, you know, there's also something called the health financing transition. You know, we economists didn't want to be left behind, so we thought we should also have that. But health financing transition is basically, it's an empirically observed trend that as countries grow and develop, not only do they spend more resources on health, but the way they source those resources tend to change, moving away from external financing and out-of-pocket spending towards much more prepaid, pooled public financing sources. So most high-income countries, the largest share of financing is actually from public sources and more from government revenues. And a lot of the lower middle-income countries, and including India, the largest source of financing remains out-of-pocket. And Given that multiple chronic conditions and multimorbidities require frequent contact with the health system, even small amounts of out-of-pocket spending can lead to foregone care, to incomplete care, where you end up trading off and not taking your hypertension medicine for the full amount or things like that. So just to also facilitate that transition to occur at the same time as you're thinking of different clinical pathways or different ways in which your health system has to be organized, it also has to be financed in a very different way, and not just moving to public financing through line item budgeting, but also how you pay providers. I know, Dr. Reddy, you yourself have done some, written some articles on this, but really there's a movement globally now to also think about how do you pay providers now to keep the population healthy. Currently, the entire health system is geared around paying providers. The sicker you are, the more, especially in the private sector, the more out of pocket there is and the more money is made. How do you turn that on its head and pay providers in a way that keeps the population healthy? Wales pays by global capitation, right? So if you're in a community in the UK, the provider gets paid $100 per year for you, regardless of whether you're healthy or you're sick, right? So that's one experiment that they're doing. And now it's in the interest of the providers to keep you away, to keep you healthy, because then they get to keep that money. So, I mean, these are simple tweaks to the system. Not always will they work, but there are ways in which you can use a powerful financing lever, is my point, to try and also get providers to align to keep you healthy, and also to try and get, I think the point was already made that one of the challenges with the NCDs is the patient themselves also have to be the provider, right? So it's not just when you seek care, it's also in between, not just in terms of taking medicine, but also activity and what you eat and things like that. So how do you also get the providers to assist and to guide, or the peers to enable that to happen, and also sort of a more multidimensional, multi-sectoral interventions to allow that to happen. The other point I just wanted to make, that some people were saying, oh, mortality is easier to measure, and as we move towards NCDs, but together with WHO, right, we are co-custodians of universal health coverage, the measurement of universal health coverage, which encourages countries to not measure mortality necessarily. Of course, you should measure mortality, but you should measure things that are much more amenable to policy. So look at tracer indicators, such as how many people with diabetes have their diabetes controlled, how many people with hypertension have their hypertension controlled. And we have a list of tracer indicators. You can adapt and adjust those. Tobacco, non-smoking rates is included, access to water and sanitation. Those are much more reactive to immediate policy changes. And also, I thought you were going to make the point about looking at hospitals, but for PMJ, every day there's now claims data that's generated, right? Real-time information of what's happening, and this is also done in the NHS. So they track hospitalizations for ambulatory care sensitive conditions, right? So conditions for which, if you had good access to primary care, you actually wouldn't be hospitalized. And again, I'm not a medical doctor. This is bad from a health perspective, but it's awful from an economics perspective, because the unit cost of treating or managing or preventing at the primary health care level are then, after a few years, felt at the hospital level. And oftentimes it's the same purchasing agency that's going to have to pay for hospitalization of these same people. So, you look at the PMJ numbers, I think it's a quarter on dialysis. Dialysis is an ambulatory care sensitive. You should actually be focusing on reducing dialysis and getting people out, not getting the need for dialysis to begin with. So, just those small things in terms of looking at the system more from a economics angle, as well as from a health financing angle, to encourage the financing levers to also help you to be healthy. And I think I just wanted to correct you. It's health and wellness centers, right? Not welfare centers. And it's not just acute change of name, right? The whole idea is you want these centers to keep you healthy, not just treat you when you're sick. So I think that's a very powerful name change that occurred. So in India, they're not called primary healthcare centers anymore. They're called health and wellness centers for that same logic and reason to try and do that. The challenge now is to get that orientation to work. But we've seen that work in many countries, in Cuba, in Brazil, in Costa Rica, this sort of very community-oriented, proactive, risk-based screening approach, and tracking hospitalizations for things that you shouldn't be hospitalized for. And, so the hospitals are left for things that you can't prevent. And just finally, one point, I think the point that you're dying from NCDs is not the problem, right? You're going to die from NCD. It's preventable NCDs that's the problem. So a lot of the mortality, that's so high numbers in LMICs are because they're preventable, not just that they're NCDs. It's that a lot of people are dying much earlier than they should be. And I think is one of the challenges that's going to face us for the next 30, 40, 50 years. And the fact that once you have an NCD, you now have it for 40, 50, 60 years. That I think is a huge challenge that not only has to be met from a clinical angle, but also in terms of how do you finance such a problem. And this is not just an issue facing LMICs. Even high income countries are struggling with this sort of a pathway in terms of how do you manage the financing of such a system. So
thank you very much. We health professionals generally ask for more money for health. You're asking for more health for the money. And yes, give us the money, we'll give you the health. Right. But I think the important thing is you also came up with a very important message that don't be just fixated on the mortality target of SDGs. It's important to look at how many people are being covered with services. And otherwise that can become a distraction, particularly when different countries are at different stages of health transition. And therefore a single target may not necessarily be applicable to everybody. Dr. Verghese, you have seen it all. You've been everywhere, from cancer registries to different WHO offices in technical leadership positions. You have every right to be cynical at this point in time as to what this project is going to achieve. But what do you really hope that this project will achieve if your best aspirations come true?
Thank you, Dr. Reddy. I think the Saptarshis have spoken, so including you, so there is nothing much left to speak. My first thing is that it should not go into an analysis paralysis. Most of the projects that people do get into extensive, I think Dr. Paul mentioned that, extensive analysis of the problem. So we get in WHO's huge documents. This problem is big, this problem is bad. So first is to sort of go very bold and do something. And again, what Dr. Paul said is that if you want one more health worker, just be firm about it and say that we need it. I always think we cause this condition called modulitis because we have a module for everything. And then we see that only 3 people are needed. They can be given modules and they can do everything. So I think Dr. Rajiv Sadanandan is here. He knows how Kerala health system was enhanced with additional 3 more doctors in the family health centers. So I think, and then find out what exactly that needs to be done. So I think all those aspects have been covered, but my wish is that show something that can be taken forward, because ultimately success breeds success. When we started with Dr. Reddy, the hearts package many years back when I was in Geneva, and then Dr. Tom Frieden started funding it. Now the governments are saying, okay, hypertension control is a good indicator. So it took time, but we could actually show that such things work. My other area is that while it is true that we are postponing death by preventing premature mortality, and ultimately multi-organ failure will happen, not just multi-morbidity. What is palliative care in this? Where is palliative care? In fact, in most of the big hospitals in this country, I would think it is advanced palliative care that is happening, because it is advanced cancer that is reaching there. And then they are being given all sorts of unnecessary treatments, whatever conditions that be. Can we optimize that? Can we optimize long-term care in such a way that it is not catastrophic health expenditure? It is not even out-of-pocket expenditure. Families go into poverty because of catastrophic health expenditure. And most of the time it is advanced cancer, it is advanced NCDs, complications of NCDs that get them into the glass and steel big hospitals in this country. Even if PMJY pays for them, when they come back, they are actually poorer. They have other issues. So I think the entire spectrum has to be looked into. Prevention, of course, is very much possible. We know about polypill. Has polypill been tried? No. Why can't this project try and look at polypill and see whether that can actually address multiple cardiometabolic risk factors? So be very grounded, practical, because there is a lot of stuff going on these days in all parts of the world. So if this agency and its outputs have to become relevant, again, as previous speakers have said, it has to be highly contextual and highly relevant in a way that it is not just more of the same. I was just looking at multimorbidity, and they usually use the 3D approach, which is disease determinants, depression, and drugs. They think that those are the three elements to look at as impact of multimorbidity management. But I think it should be, again, as the colleague from World Bank said, it could look at reduction in out-of-pocket expenditure, optimization of care, optimization of palliative care, and ultimately looking at improving quality of life, not just postponing mortality. Thank you.
Thank you. That's a good note to end the panel on. I believe that there is a Q&A component as well in case there are questions to be directed. There are a few minutes still available, but I think Professor Kunti and Professor Prabhakaran should come up here as people leading the project, because the questions are not going to be directed only to the panelists, but to the principal leaders of the project. No. Yeah, you can stand there. You can. Any questions from the audience for either the PIs or for any of the panelists?
Namaste. My name is Preeti Chauhan. I'm representing an NGO called Pallium India, and I also work in research. I am by profession a psychologist, so I will have a mental health aspect to my question as well. I was actually working on a paper on a palliative care sectorial health related paper, which was basically covering 11 countries, which was a WHO CERO study as well. While working and researching for papers, we were only able to find, particularly in India, papers which were written based on literature review, not on evidential or field work. So that actually hindered our research a lot, and we were not able to find evidence of how morphine or other analgesics were available in India and things like that. Similarly, for mental health, how psychosocial care helped people with NCDs and who were actually taking palliative care treatments in India, I was not able to actually find any data on it. So the gaps that are in the field, how are, with the help of this initiative, how are we planning to actually address the gaps that are already there? Thank you.
So I think the point is very valid. There are two aspects to your question. How are we going to address conditions like mental health disorders? That's one. And second is where is palliative care in this? Dr. Cherian also asked this question. So it's part of the mix. It will be there. So when I presented, I said we are going from health promotion at one end to rehabilitation at the other end. So palliative care is part of that. I mean, it's not exactly rehabilitation, but it's going to help the patient cope with the disease, the family to cope with the end of life. So that's the kind of thing. So it's part of that mix. Mental health is a very important component of this particular center, and it's a centerpiece actually. And mental health is a major issue because it does two or three things. Number one, not only it prevents people from getting the right treatment and adhering to the treatment, but also it has issues in relation to the caregivers. Caregivers also get mental health if there is a problem in the family. So it will address holistically these issues. So we will look at the mix, we will look at the solutions, and there are international examples from UK. We will contextualize that, make it culturally sensitive here and use them.
Any other questions?
Yeah, I was just going to add to that. This is the reason I'm really excited, because this is about picking people up in primary care. I'm a general practitioner. I'm not a clever person like a cardiologist like Prabhakar or a Professor Tandon there who's a diabetologist. They only look at HbA1c and he looks at blood pressure. I'm a proper doctor, a general practitioner. And we look at everything together. And mental health is a key aspect of multiple long-term conditions. If you look at all the epidemiological studies that we've been doing in the UK, there are a few aspects. One is depression is the highest in people who have the more conditions in terms of multiple long-term conditions. And if you go to the frameworks, what is it that people with multiple long-term conditions want? The two outcomes that they're interested in. One is mortality. We're not going to be achieving mortality outcome improvements in this short period of time. But the second one, I'm pretty certain if this study goes well, we can improve outcomes. And this is quality of life. Quality of life is so important to people with multiple long-term conditions. And I think if we can manage to pick up mental health and treat that, that will certainly improve their outcomes, that they're important to them.
Dr. Kunti, GP is not only general practitioner, it's actually the genuine physician. All specialists are pretenders. Any other questions?
I represent the interest group of environmental and occupational health, and specifically occupational and environmental epidemiology. I believe these are the two important causative agents. Very little analysis has been done. Even in Western literature, it hardly has studied what is happening in the developing countries. Now, I have full understanding, and Dr. Prabhakar would also agree with me. Environment has a very important component or determinant on these multiple long-term conditions, not only on their causation, but in terms of their evolution over a period of time. So I believe and trust this aspect would be analyzed in this research that you're going to hold. One. Second, hardly any discussion happens on the occupational aspects of multiple long-term conditions. And we know it for sure, because that is the immediate environment that most of the people are concerned. And all of us know most of the people that work in our country belong to unorganized sector. And they are exposed to multiple causative agents just because of their profession. So are we looking into that? Because that is so fundamental. And Mr. Ajay Chandan will agree with me that occupation determines your ability to not only manage, but your ability to actually have disease in the first place. And then multiple diseases happening just because you are practicing that profession for maybe 40, 50, 60 years.
Right. I think both are very, very important questions. In fact, I was talking to Dr. Joel Schwartz outside and said one of the areas that we would like to work in this, in terms of the PhDs and postdocs, is to look at the effect of air pollution, look at environmental determinants in terms of multiple long-term conditions. So there is a plan already there. Second, Dr. Reddy and I have worked in worksite interventions long time back. And there we saw that worksite has actually the highest burden of multiple long-term conditions, more than the community. NCDs are higher, so consequently the multiple long-term conditions are higher. Along with this project, we have other plans in terms of expanding this. So there will be a worksite component as an add-on subsequently.
I just wanted to add and agree with you that the effect of the environment and on the burden of NCDs is very, very clear. So one of the centers we are funding, I said initially there are 5. One of them is looking at the effect of the environment on NCDs. And that project is in India. It's the George Institute. So again, the experts who reviewed the 40 applications felt it was very important to get some data on it. So thank you very much for that.
Yes, please.
First of all, congratulations to all of you. And it's so timely that I just finished with one of the NIHR funded projects on addressing smokeless tobacco in Asia, where India, Bangladesh, Pakistan, and 8 universities of UK were there. But what I wanted to say was that we have to keep in tune with whatever is existing. As Dr. Paul also mentioned, we do have cascade level trainings, from district to down below till the last mile. So we have to keep in mind that there is no conflict. We follow the standard guidelines. And second thing, which is very important, is Dr. Paul, what he mentioned about community health officers, they are not all staff nurses. First of all, we have to keep in mind their contractual positions, where they're hardly acceptable to their own people, who are the regular employees. So we have a lot of challenges, and I'm sure we'll be able to overcome this over a period of time. Thank you so much.
So thank you. Actually, I just wanted to add to what Dr. Reddy had this 10 commandments in terms of intervention. I don't remember all the 10. I remember 4 or 5, and he can complete the remaining. So he said any intervention that we develop has to be culturally sensitive, context specific, equity promoting, evidence-based, and you can complete the remaining.
Don't challenge me so that I will not get diagnosed with Alzheimer's.
So just a very brief follow-up on your comment about sort of mental health, and I think it's critical, but just to point you in certain directions, I think the diabetes and comorbid depression is an area of which reasonable amount of work, not only in understanding, but intervening. And we've formally tested interventions in which concurrently, so screening people with diabetes for depression, and then intervening there to not only evaluate diabetes-related indices, but depression-related indices. And actually, that's been demonstrated to be of significant benefit. So there are literature from within the country for you to go back and look at.
There are only 2 studies in the world. One of them is from India. That's an independent study of which you are the PI.
We'll take the last question from the last row.
Hello, everyone. My name is Mena. I'm representing the George Institute for Global Health, which Ms. Sylvie just mentioned. My question is, when I read the phrase multiple long-term conditions, I find it quite synonymous to the lived experiences of people with disabilities. So I just wanted to know if you would be seeking or involving people with disabilities as a major community member, involving them in the research, because the experiences of people with disabilities and able-bodied people, and both of these two key stakeholders, they face multiple lung conditions very differently, and their access to the primary healthcare that we've been talking about is also very different. People with disabilities face a lot of discrimination and stigma. So just want to know how much will you be addressing all these as well? Thank you.
So when you research multiple long-term conditions, as I said earlier, it's in its infancy. And we've done systematic reviews that show there's over 200 conditions that you can combine. And there is no way we can look at 200 conditions. So our framework is to look at the data sets that we've been talking about it today. What are the biggest clusters affecting people in India in terms of multiple long-term conditions? So this is the early phase. We're just starting with this. So initially we want to tackle the highest burden of disease clusters. And it may include disability, we're not sure. But we think it's likely to be the common conditions that people die of in India, and these are the cardiometabolic, respiratory, depression. But this will be all done during the cluster analysis, and then we'll pick the key conditions. We can't do everything straight away.
Thank you. And I think one thing that should be picked up from persons with disabilities is their slogan, nothing about us without us. So I think that is something that should be imbued into this whole project. I'm sure there are many other questions and comments, but we have already exhausted the clemency of the clock. So I'll pass it on now, back to the MC to conclude.
Thank you, Professor Reddy, and our distinguished guests and members of the audience for such an enlightening discussion. I would now like to request Professor Sailesh Mohan, Director, Center for Chronic Conditions and Injuries at Public Health Foundation of India, to deliver the vote of thanks.
Good evening, everyone. I'm really privileged and honored to propose this vote of thanks on behalf of the Public Health Foundation of India and all our collaborating partners. I'd like to extend our sincere gratitude and heartfelt thanks to all the esteemed dignitaries who have graced this occasion. The Honorable Member, Niti Aayog, Professor V.K. Paul, Dr. Rajiv Bahl, the Director General of Indian Council of Medical Research, Professor Sanjay Zotpe, the President, Public Health Foundation of India, Professor Kamlesh Kunti, the Director of the NIHR Center and Professor at the University of Leicester, Dr. Sylvia Annie, Senior Program Manager, NIHR UK, and our Founder President, Professor Srinath Reddy, who has been a mentor and constant source of guidance to all of us in our work in NCDs, as well as all the distinguished panelists on the dais and people who have joined us in this room as well as in the virtual space. Thank you, everyone, for making this event a truly successful and memorable one. I would just spend a couple of minutes to describe how hard many people worked to secure this grant. It's been a truly collaborative effort between several institutions. First of all, I'd like to thank and place on record our gratitude to Professor Kamlesh Kunti, who at very short notice agreed to collaborate with us when we were very desperately looking for a partner. I'd also like to thank Professor Nikhil Tandon for connecting us and making this collaboration happen. We also want to thank all our co-applicants, all our partners, Professor Kuldeep Singh, Dr. Monica Arora, and Professor Abhinav Vaidya, who have worked tirelessly with us in this journey. It has been a pleasure working with everyone. I'd be failing in my duty if I don't mention few key people who have been tirelessly working with me in the back room. So we have Shabana and Patrick, if you can raise your hand, from the University of Leicester. And we have Nikhil SB from PHFI. Nikhil. So under the leadership and guidance of both Professors Kunti and Prabhakaran, we have enjoyed this experience and we are tasting the fruits of labor. Lastly, I'd like to thank all the colleagues who have helped organize this event. Thanks are due to Suma, Aarti, and Sanjeev, who have made all the arrangements, including travel for many of the people. Ladies and gentlemen, thank you again for coming here and gracing this occasion and making it very successful. I also want to thank all the colleagues and friends who have joined online and stayed with us. Thank you again and have a great evening.